Okay, hello everyone, and welcome to today's session. On behalf of the Special and Vulnerable Populations Task Force, we'd like to welcome everyone to our first webinar of the four-part National Learning Series focused on specific areas of the Diabetes Continuum of Care framework based on our health center feedback from last year's series. Our first webinar today will discuss team-based care as one main strategy for diabetes prevention and management. My name is Joe Lee, and I am the Training and Technical Assistance Director of the Association of Asian Pacific Community Health Organizations, or also known as APCHO, and I'll be serving as your moderator today. I am joined by my colleagues, Albert Eisen and Christine Alarcon, as well as Jillian Hopewell from the Migrant Clinicians Network, and we will be serving as your moderators and organizers for this four-part series. So before we dive into our presentation portion, I want to go over some quick Zoom housekeeping reminders. As an attendee on today's webinar, you'll be able to use certain features. You can click the unmute button to mute or use your microphone. And next to that microphone icon, you'll see the up arrow on the right side. You can choose specific audio settings for your microphone and speaker system. During the presentation, you may also ask questions. We encourage you to click on the Q&A box and type your questions into the open field. Myself, as the moderator, and my colleagues will either send a typed response or answer your questions live. And attendees can also upvote or comment on open questions. So if there's a popular question that you like to be answered first, feel free to upvote by clicking the like button. We also have a chat function for our attendees here to communicate with all panelists and or attendees at any time during the presentation. This chat box may be used for any troubleshooting. If you have a question during the Q&A time, feel free to raise your hand and we'll be able to open up your audio for you to ask your question. And afterwards, you can just click lower hand to be dismissed. And when you leave the webinar, if you want to leave the webinar, click Leave Meeting, and you will be prompted to complete a short post-webinar survey. Your feedback makes a difference for us to provide high-quality training and technical assistance for future events. And today's webinar will be recorded and made available for our audience after today. We'd like to note that CME and CNE accreditation will be made available. Please complete the post-webinar survey if you'd like to receive CME or CNE units or a certificate of attendance. You will have the option of indicating whether you'd prefer an electronic or hard copy of your certificate. If you have any questions, please contact Martha at this email address listed here. So this National Learning Series was created to address our diabetes epidemic, which is affecting more than 30 million people across the US today. To combat and continue the national conversation around diabetes, the Special and Vulnerable Populations Task Force created the series to increase knowledge of effective strategies to prevent, treat, and manage diabetes among health center program patients. We'd like to acknowledge HRSA's support in our task force efforts in decreasing the percentage of health center program patients with A1C greater than 9. The task force is currently represented by these wonderful 14 National Cooperative Agreement, or NCA, organizations funded by HRSA, and we are all dedicated to improving the health of special and vulnerable populations served by all health centers. These 14 NCA organizations have partnered and collaborated for the past 1 year to create meaningful content and provide access to expert guest speakers for our audience today. For more information about our NCA partners, please visit diabetes.apcho.org. So we want to recognize and acknowledge the current and very quickly evolving environment around COVID-19. We just want to acknowledge that health centers play an absolutely vital role in the national response to the COVID-19 virus. in part by making patients aware of COVID-19 preventive measures and determining if patients need COVID-19 testing and so forth. We've seen across the nations that health centers have coordinated with state and local health departments as part of emergency and management planning, and by continuing to provide primary care to their patients. And that we've seen that health centers are also relieving congestion in hospital emergency rooms that may become crowded with patients seeking care for COVID-19 infections. I'd like to just highlight here that there are 20 NCA organizations, and we are all, that's funded by HRSA, and we are all collating COVID-19 resources for very specific special and vulnerable populations, and they're being collated under the Health Center Resource Clearinghouse. Under the Health Center Resource Clearinghouse, if you click on the Priority Topics tab, you'll see COVID-19 as an option. And we encourage you to check out all of their resources, the fact sheets, the past webinars and upcoming webinars, and other TTA activities available for your health center around addressing COVID-19. We also want to acknowledge that there is a relationship between COVID-19 and diabetes. We are learning that people with diabetes are not more likely to get COVID-19 than the general population, and that people with underlying chronic medical conditions like heart, lung disease, or diabetes seem to be at higher risk for developing more serious symptoms and complications when infected with the virus. And if one's diabetes is well managed, the risk of getting severely sick from COVID-19 is about the same as the general population. We have a ton more resources about COVID-19 and diabetes around complications and just recommendations for diabetes management with COVID-19. And we encourage you to check out these resources that we have laid out for you by the American Diabetes Association, the Association of Diabetes Care and Education Specialists, CDC, and Joslin Diabetes. These links will be made available on the slides, which will be sent to you after today's webinar. So today's agenda will include a 90-minute presentation with a Q&A immediately following. Our learning objectives will be threefold. One, to increase your understanding regarding team-based care and why a multidisciplinary team approach to diabetes management is important. Two, explain how to develop a high-functioning diabetes care team. And three, discuss promising practices and provide examples of team-based care models. So before we launch into our webinar, we'd like to share a couple of slides and a wonderful recording prepared by Tracy Branch, HRSA's Senior Advisor of the Strategic Partnerships Division with the Bureau of Primary Health Care. So I'm going to press this recording or play this recording, and hopefully you'll hear Tracy's voice.
Thank you for joining today's webinar and for your continued work to improve patients' diabetes health outcomes within your respective facility. Over the past 2 years, as part of the operational site visit that health centers are required to have, health center staff have taken part in diabetes performance improvement coaching designed to help identify the root causes of a health center's contributing factors of success and the restricting factors that create challenges for health centers in the ability to improve patient diabetes testing and control. The Bureau of Primary Health Care has recently completed an analysis of the past 2 years of the performance improvement plans, cataloging root causes, namely the contributing and restricting factors of diabetes control.
Great. I'm going to play this next slide and a few minutes of recording by Tracy here.
This slide depicts the contributing and restricting factors that health centers identified during their operational site visit diabetes performance improvement coaching sessions. The left side of the slide provides the contributing factors that health center staff identified as helping them be successful in diabetes management, while the restricting factors on the right were those identified as being barriers to success. The items that are highlighted in red represent the factors that were identified by health centers across both the 2018 and the 2019 site visit period. The items in blue are those identified only during the 2019 site visit season. In keeping with the theme for today's webinar, you will see that health centers find that employing Multidisciplinary or team-based care models have significantly improved their diabetes health outcomes. A benefit of developing this model of care is that it is effective beyond just diabetes, and when employed, can improve the management of most chronic diseases, as well as acute care management. An additional benefit is that a multidisciplinary care team model can also address some of the factors identified as restricting factors, namely staff turnover, short patient-provider appointments, poor care coordination, and the lack of provider buy-in. Multidisciplinary care teams are fluid and unique to the facility and the needs of the patients that they serve. They build increased capacity within the facility and staff, improve patient engagement and health literacy, and ultimately improve patient health outcomes. Facilities that have institutionalized a multidisciplinary team approach are more successful in managing not only chronic disease, but also acute conditions. The current COVID-19 pandemic is a perfect example of how an established process that utilizes not only primary care providers, but includes pharmacists, behavioral health specialists, community health workers, and other health team members is going to be more effective. It's going to be a more effective system in engaging, educating, and managing patients in an emergency situation. It is my sincere hope that if your facility has not yet adopted multidisciplinary or team-based care models, that you will use the information provided during today's webinar to explore strategies to bring team-based care models into your facility. Thanks for joining. With that, I will turn the webinar back over to Jolie.
Great. Thank you so much, Tracy, for that wonderful content and sharing your thoughts. Your partnership is greatly, greatly appreciated, and we really value your guidance and feedback in helping advise the National Learning Series on diabetes prevention and management. So with that said, I'd like to introduce to everyone your NCA faculty for today. We have Colleen Velez from the Corporation for Supportive Housing, Kay Lambert from the National LGBT Health Education Center in Fenway Health, Darlene Jenkins from the National Healthcare for the Homeless Council, and Irene Hilton from the National Network for Oral Health Access. And we will have expert guest speakers from health center programs, including Tonii, Gedin, Tracy Russell, and Mara Schneider from the Baltimore Healthcare for the Homeless program, as well as Jamie Carter from Health Partners of Western Ohio. So with that said, we're going to kick off the content. This presentation was Colleen Velez, the Associate Director of Corporation for Supportive Housing. Colleen?
Thanks, Joe. You can go to the next slide. I'm just going to take a couple of minutes to just do some quick framing and basically reiterate what Tracy's message was to everybody, talking about the what and the why, and some certain aspects around what it means for special and vulnerable populations in diabetes care. So next slide. So team-based care, as you can see, this is the basic definition. I'm sure you guys have seen it over and over and understand what it is, right? But it's the provision of health services by at least two health providers who work collaboratively with the patients and their caregivers, right? So sometimes it's 2, sometimes it's 5, sometimes it's 10, but that's the basic definition around what team-based care is. Next slide. So when we talk about team-based care in diabetes, a lot of times that team itself is based on not only the condition of diabetes, but what other underlying conditions can occur because of diabetes or because of conditions that the patient may already have. This list has come from the American Diabetes Association when they're talking about kind of the gold standard or the big big clinicians that are usually involved or should be involved in team-based care when we're talking about diabetes and diabetes management. It's including your primary care, your endocrinologist, your ophthalmologist, podiatrist, pharmacist, dentist, right? Anything that not only deals with diabetes management, but what other underlying conditions can occur from diabetes or people may already have in co-occurring. So building that team-based care model and really making sure that based on what your patient's needs are, you're building the team around that patient and having those specialists on hand for things that may not be occurring now, but could occur later with conditions underlying from diabetes. Next slide. So again, this is just a great little graphic around team-based care and having team-based care and surrounding that patient. And what we'll talk about later when we're talking about the models and when our presenters talk about how they do their team-based care models, it's going to depend on your health center, right? So there are some things that may be within your doors, right? Your primary care, your nurses, your dentists, your podiatrists may all be within your doors, or they may not be. So you have to make those connections and partnerships with other clinical specialists that may not be within your four walls, but still need to be a part of your patient's team care. The other piece that we really want to highlight here as part of the special and vulnerable populations is that then it also takes on the coordination, but also care coordination. And then there's the second level of care coordination for special and vulnerable populations, right? So not only clinicians that are involved in their diabetes management and their diabetes care, but many times because of social determinants issues that they're having, or what their living situation is, if they have food insecurity, things like that, there is care coordination for diabetes management that not only has to go outside of the four walls many times, or outside working in a team base with other clinicians, but working with that non-clinician staffing, right? So if they have a case manager that they're working with that's not linked to your health center, there should be care coordination that goes around, making sure that they have transportation, making the care coordination around food banks or where they're getting their food if they have food insecurity issues. Again, behavioral health or support groups that they can tap into for diabetes management, and extra support around those healthcare issues. So for special and vulnerable populations and talking about team-based care, we always want to be considering that the broader circle and the care coordination that has to happen around those patients, not only within the walls, only within clinical activity supports, but for non-clinical supports. Next slide. Again, and then some of the key components to making that care coordination happen, whether with its clinicians outside of your four walls or non-clinicians or case managers, things like that, having the ability to have sharing some level of patient data with each other, so everybody knows what each other's is doing around that care and around diabetes management, having some form of defined team structure so everybody understands their roles and responsibilities on the team, how they're going to work with the patient, who's going to do one aspect of work and then another person picks up somewhere else, right? Being able to define what that structure is of the team and what the roles and responsibilities are around that. Obviously, doing coordinated care planning with the patient and with the entire team, building those strong partnerships between clinical and non-clinical supports, and supports, again, that are within your health center's four walls or those that may be without. Obviously, working in a trauma-informed and harm reduction approach, right? Especially those that are special and vulnerable populations. They may have histories of trauma. Obviously, we're doing a team-based care. You don't want to re-traumatize. You don't want to have everybody having the same conversation with that person that may be triggering or create trauma for them, right? Having that coordinated care planning and really working where people are at when they're presenting to you at the door. And meeting those needs, and then building the care plan around to make sure that all the aspects of health and diabetes management is folded in. Next slide. And then again, just a kind of the reiteration of why do we do this? And Tracy had spoken to that in the beginning as well, right? It's improved patient experience. It is improved provider relationships and the relationships with the patients and the providers themselves, right? If you really are coordinated and working as a team, you're building those partnerships with your different disciplines or non-clinical connections that you have outside. And then obviously their experiences with all the providers is improved. You know, at the end of the day, you are going to see increased health outcomes and decreased A1C and health issues related to diabetes care. It's shown when you have this multidisciplinary team approach to diabetes management and prevention that the health outcomes are seen and A1C is lowered at the end. So with that, that is just my basic framing, and I think I'm going to pass it back off to another one of our wonderful faculty, Kate.
Thank you so much, Colleen. That was great. So I'd like to introduce you to Kay Lambert. He's the program manager of the National LGBT Health Education Center and Fenway Health. So Kay, you have the virtual microphone.
Thanks so much, Joe. And I'm going to be talking a little bit to follow up on what Colleen began with. I'm going to dive a little bit deeper into a specific special and vulnerable population, which are sexual and gender minority patients or LGBTQIA+ patients. You may have seen this phrased a few different ways. Next slide. So I also wanted to address a couple of components about COVID-19, particularly because, as with diabetes care and in conjunction with diabetes care, care for sexual and gender minority patients works best in a team-based framework. And there are particular needs that the sexual and gender minority community have during this pandemic. One of the things that we've learned is Fenway Health really provided care at the forefront of the AIDS epidemic, and we're hoping to use the lessons that we learned during that acute health crisis to inform our best practices for dealing with COVID-19. And some of these seem really obvious, but I think they bear mentioning. Practice kindness, compassion, and beneficence, the desire to do well by other people. While you are staying safe, using personal protective equipment, whatever you need to be doing, and not avoiding unnecessary physical contact, but not avoiding physical contact at all with patients out of fear. So if you are a healthcare provider, definitely protect yourself. But one of the things we saw during the AIDS epidemic was that providers would recoil from other human beings and make those people feel very isolated, and we don't want to do that. Providing equal and optimal care for all patients, regardless of their infection status with COVID-19, and then just helping each other. Whether that's helping somebody to do a task that they can no longer do because they're in quarantine, whether that's helping your colleagues because we're all totally overwhelmed. I think that those are all really important components, and they work best, all of these practices work best in a team-based context. Next slide. So specifically for sexual and gender minority people, one of the things that we are seeing is that with the COVID-19 pandemic, there is a strong emphasis on what is medically necessary and what is not medically necessary. Sexual and gender minority healthcare is medically necessary, and it is critical care. It can't abruptly stop because of COVID-19. So for example, transgender patients need their hormones refilled, and this is medically necessary and critical. For patients who are using PEP, which is pre-exposure prophylaxis, or PrEP, pre-exposure prophylaxis, for preventing HIV, medication filling and monitoring of those medications must continue. And one of the things that I've been talking about is if you're able to make time to take care of your diabetic patients' needs around their diabetes, you can make time to take care of your sexual and gender minority patients' specific health needs. And one of the things that I love about team-based care is that if you have somebody who's engaged in work with a primary care provider who may also be seeing a nurse, who may also be working with a case manager, and maybe that person has diabetes and is also a sexual and gender minority, that person may have several needs and a lot of fears. And in a team-based model, you can help to support that patient by spreading the load of what is needed across the team, and in so doing, ensure the likelihood that your patient is actually going to get all of the different pieces that they need. Next slide. So I have got a polling question here, which Joe and Albert are going to help me with. So you should see a poll pop up on your screen. I want to hear from all of you if you could interact with the poll. Across your health center, which people in your health center care for sexual and gender minority patients, LGBTQ patients? And your answer options are a single medical or behavioral health provider, multiple medical and behavioral health providers, all medical and behavioral health providers at your clinic, or all staff, including nurses, case managers, frontline staff, medical assistants, navigators, all of those different pieces. So I'm seeing some trends popping up here as folks are responding. It seems like the majority of the responses, we've got 95, over 100 responses saying that they are engaging, that they are caring for sexual and gender minority patients with all staff. So that's really wonderful news. I think that that is absolutely what we should be doing, and is indicative of people using a team-based care model to help provide care for these patients. So we can close the poll now and move on to the next slide. Okay. So talking about team-based care specifically for sexual and gender minority patients, a lot of clinics view LGBTQIA+ care, and especially transgender, gender diverse care, as specialty care that can only be done by a unique provider. What we know is that this is not the case, and that it's a destructive model to think so. Sexual and gender minority patients are best able to manage their health care and achieve better health outcomes when they have a team of providers just like any other patient. So that includes primary care providers, nurses, case managers, especially since services for sexual and gender minority people are often challenging to get covered by insurance. So those case managers might be helping to navigate insurance questions, and also frontline staff. One of the other things we do know about the sexual and gender minority community, especially people who identify as lesbian women, is that those individuals have a higher rate of obesity and a higher rate of diabetes than the general population. And so for these individuals, when we think about an intersectional model where this person is all of their identities, we have to understand that we can't address somebody's diabetes in the absence of their other identities and their other health concerns. And so helping to support the person in their sexual and gender minority identities through team-based care will help with their diabetes management and adherence to the recommendations that the healthcare providers make. Next slide. It's very important to train your whole team to care for sexual and gender minority patients. It's important that staff are given support and resources to pursue further learning about the needs of LGBTQIA+ patients. And it's also important to know who on your staff is a champion who knows about sexual and gender minority health and help support that person in educating and training staff. And something I really want you all to take from this as we start to think about team-based care is if you have a sexual and gender minority healthcare champion in your workforce, that person needs time, space, and compensation to do training and to do mentoring. If more work is asked, more tangible support must be given. And so this is true across the whole team-based care model. If you are going to be asking people to do more work around supporting patients, they need to be given the time and ability to do so. And if they are given the time and ability to do so, I think what we've found at least is that the overall work burden for everyone tends to go down because primary care providers aren't necessarily having to field every single insurance question. We're having nursing staff who are able to help a transgender patient to do their weekly shot instead of that person having to make an appointment with their primary care provider. And so if everyone's on board and everybody has been able to get the training that they need and the support that they need to provide this care, we see better outcomes. Next slide. Continuing with the idea of training your whole team to care for sexual and gender minority patients, mentorship is a wonderful model. It's appropriate to look for mentorship within an organization, and that can build a lot of trust and good collegiality within the organization, but it's also available from outside agencies. One of the models that we certainly use a lot of is the ECHO virtual learning model. We provide this in a number of different subjects. One is transgender health. We also have another that specifically focuses on PrEP or pre-exposure prophylaxis. And these mentorship models can help your whole team to understand better what it is that's needed to support all of these patients. And then again, training for all staff. Providing excellent care for anybody, including sexual and gender minority folks, requires that all staff at a health center receive training. And so if everybody across the board has training to provide ideal care for sexual and gender minority patients, so that means understanding how to ask about pronouns, understanding how to ask about names used, talking about family structures in open-ended ways so that people can tell you more about how their family is built, those sorts of things. One of the things that we've seen is that people become very engaged in care with a team-based model, and that in a lot of situations where we're managing multiple health needs, for example, somebody who identifies as a sexual or gender minority person who also has diabetes, we can set that person up so that when they come in to receive care around their gender identity, for example, maybe they come in on a weekly basis to get a hormone shot, we can also use that opportunity to talk with them about their diabetes and to do a check-in, or we can schedule them a nutrition appointment to be right after their shot, something like that. So using a team-based care strategy that focuses and helps people feel like their identity is recognized, acknowledged, and being taken care of can also help us to get that person into the other needed care that we want them to be engaged with, including diabetes management. Next slide. So here's another polling question that'll pop up. So the question is, if you have a patient who has type 2 diabetes, do you, option 1 is manage all their care using one primary care provider? Do you manage their care with a combination of a medical provider and a behavioral health provider? Do you manage their care with multiple medical staff, nurses, primary care providers, medical assistants? Or do you manage their care with all patient care staff, so primary care providers, nurses, medical assistants, case managers, insurance navigators, lab technicians, and so on? And we're again seeing a really good trend here, well over 100 responses saying that folks would manage the care with all patient care staff, including not just the clinical care folks, but also those case managers, insurance navigators, lab technicians, and thinking about community outreach workers as well, to Colleen's point from earlier. So I would definitely argue that for a patient with type 2 diabetes, a team-based care model where they have access to all of these professionals is going to be helpful. Thanks for your answers on that. Next slide. So takeaways from this particular segment is that sexual and gender minority people have improved health when they're supported by a medical team, not by a single provider. Much of the specific care for sexual and gender minority patients can be done by other members of a medical team, which frees up primary care provider time. And then lastly, sexual and gender minority patients are at higher risk for diabetes than the general population, and ensuring that these patients are getting their needs met throughout their experience in your clinic improves their adherence to medication and treatment, and therefore for better health outcomes. And this is widely documented, but just one area where you can see this written out is in an issue of Diabetes Spectrum that I've linked to here. Next slide. I would also encourage you all to take a look at our website. We have an enormous number of resources, including webinars and training modules, most of which are available for continuing medical education credits. And we also have a lot of publications, including this one, on recruiting, training, and retaining LGBTQ proficient clinical providers. And this toolkit could really help you to understand what do you need to do to do team-based care and create a team that is ready to serve sexual and gender minorities. Next slide. So with that, you can put some questions in the question and answer session, and then I think we're going to move on ahead to our next speaker. Thanks, everyone.
Thank you so much, Kay, for that wonderful content. I'd like to next introduce to you Dr. Irene Hilton, who works as a dental consultant of the National Network for Oral Health Access. Dr. Hilton, you have the virtual microphone.
Thank you, Joe. So my topic, and welcome everyone to the webinar. My topic, I'll be spending a couple of minutes talking about high functioning teams and some of their characteristics and how to develop them, and give some examples setting up the groundwork for the presentations from the health centers. Next slide. So again, Colleen mentioned and Kay both mentioned the care team, which can be composed of so many different individuals, not necessarily just what you would traditionally think of as healthcare providers. So part of my presentation is just about reminding or sharing with everyone, dentists can be part of your healthcare team. Next slide. So there has been work that's been done about the attributes and characteristics of well-functioning team, and this is just some of the key ones. Well-functioning teams have role clarity about what each person on the care team is doing. People that are in their roles have received training specifically on their role and how they interact with other people on the team. And in general, team members are working to the top of their practice. There's team communication, constant communication, especially when you're trying to work on the workflow for visits for diabetic patients, for example, and how the different members of the care team are going to interact and at what point in the visit. And frequently we need teams, the most well-functioning team have subject experts that may have expertise that's related to the specific needs of the patient population, of your health center population that has diabetes, and that starts with language congruity and goes on from there. But the key is that the members of the team are all their presence on the team is driven by the patient service needs. Next slide. So for my particular part of the webinar, I'm going to use as an example or focus on, if you look at the HRSA strategies for preventing and managing diabetes, under the section here about optimizing provider and multidisciplinary teams, and looking at this one criteria of that somehow our care teams are supposed to be able to provide for each patient that has diabetes an eye, a foot, a dental, and a kidney screening, and how might that possibly look in real life. Next slide. So this is just one aspect of many, many strategies on how to provide team-based care. But again, it's the one that I know best and we know best at NOAA because of the work we've done with HRSA. And that is, and it's almost like a foundation for team-based care, is the integration of oral health and primary care practice. And in this, and it's bidirectional. So in this framework, the primary care provider provides multiple screening, can provide multiple screenings for many conditions, such as the foot and the oral health, the dental screening, and then refers as appropriate, to resources that have been identified, other team members. So training is about training primary care providers to understand what's normal and abnormal in oral health. And then at NOAA, we have developed a framework of how we implement these kind of integration projects, which actually go bi-directionally because we also have many health centers where the dental programs are doing screenings for diabetes, whether it's H1C testing or glucose, point of service glucose testing. Next slide. So in terms of the primary care side, and these don't necessarily have to be for oral health, really it's any core clinical competency for any discipline that isn't, we'll say, primary care. And that is that providers need to understand how to do risk assessment and evaluate and talk about patients, again, if you're thinking about in terms of diabetes and oral health, and communicate, like, let's say, the relationship between diabetes and oral health, and then be able to refer or bring in and pull in other members of the team. Next slide. So this is actually the framework that we developed at NOAA, again, for our work in integrating oral health and primary care practice, which is that there's always a planning phase. But again, this framework can really be applied to bringing in any, we'll say, other person, like an acupuncturist or the attorney or social workers, into your team-based care. And the first is there's always a planning phase about everything. So these are systems. It's all about creating a larger overall system with the patient that has diabetes in the center of it, as you've seen in all these other individual disciplines, interacting with them. And like I said, in general, there's a planning phase. There's training systems that have to be developed because people need to understand, how to do things, like what their role is and how to document and how to interact. The IT piece is critical, developing an IT system that allows documentation, again, of all of these, for all these providers to come in and see the patient. And the clinical care system then flows from all that. And this is like a place where quality improvement and using PDSA or whatever methodology you use will allow for the development of a smooth running system that, again, is going to bring all the different team members to the patient with diabetes. And lastly is developing of an evaluation system that can track both process and outcome measures. Next slide. So here we have our patient, Mr. Garcia, who's related. If we were on the webinar we did last year, one of the webinars, we had Mrs. Garcia, his wife. Now we have Mr. Garcia, who's 70 years old and has this is his first visit since his new diagnosis of diabetes. So next slide. So just to briefly review that remember that there is this relationship between oral health and diabetes. And more people that have diabetes are more likely to get periodontal or gum disease. But also, if you have severe chronic periodontal gum disease, it's like a chronic infection. So, it impacts your glycemic control. And then what happens is your teeth get loose and you start losing teeth. And when you lose teeth, you're not able to eat the healthy foods, fruits and vegetables that help you control your diabetes. So you get into this cycle of eating, soft junk food, which doesn't help. So so the oral health piece is important. So next slide. So here we have an example. And again, this is just to set up the health centers that are going to be talking about their specific way that they do things. But here's let's say an example of Mr. Garcia. He's come to his visit. He's with his primary care provider. If we go back to the original HRSA guidelines, the primary care provider, how are they going to make sure that there's an eye screening, a foot, a dental, and the kidney screening? So with Mr. Garcia, again, at his first visit, and we can't answer the eyes because that's the one where you're going to have a referral, to the ophthalmologist, and the ophthalmologist, the health center doesn't have one on site. However, they have contracted one. They have contracted with a community ophthalmologist. And so a care coordinator who's part of the team is going to come in after the appointment or during the appointment, is going to make Mr. Garcia an appointment at the contracted ophthalmologist in the community, who's, again, another member of the care team. For Mr. Garcia's feet, the primary care provider does, a quick assessment and sees that he has an ingrown toenail. Now, fortunately, this particular health center, after much trial and error, has decided they have an in-house podiatrist that comes once a week, and they have figured out a way that they schedule most of their diabetic patients on a day for, whether it's initial or continuing visits when the podiatrist is there, so that the podiatrist will be able to see Mr. Garcia right after his primary care appointment so that he can start getting his regular exams, and in this case, getting his ingrown toenail taken care of. So same day, max visit. For dental, the primary care provider does a screening, looks in the mouth, does notice that there's inflamed gums, and Mr. Garcia tells me he has a loose tooth. So again, the same care coordinator is going to make him an appointment before he leaves with the health center's dental clinic, using the integrated EHR that allows primary care, or allows all staff, let's say health workers, to make appointments directly in the dental scheduling system. And for the kidney labs, at this moment, Mr. Garcia is within normal limits, but the primary care provider is enrolling him in a diabetes education group, another part of the care team, along with the dentist, the podiatrist, the ophthalmologist, and the care coordinator, so he can start going to some classes that will hopefully maintain his kidneys. Next slide. So that was an example of how it could work. So just one quick minute about the COVID and the health center dental program response. So Again, it varies from state to state, but I think I can say today that the majority of states in the United States have recommended or mandated that dentists currently only perform emergency visits for purposes of social distancing and to prevent future visits that might end up in the ER. As you know, there's issues with inappropriate ER utilization for dental conditions. However, at the same time, patients that need dental emergency visits most frequently will need treatments that are aerosol generating procedures, like surgical extractions of teeth and drilling of teeth to remove cavity so you can put in temporary. So we have this conundrum because many health centers do not have the PPE required to do these procedures. And we're all waiting for guidance from CDC on revised infection control procedures for dental practice. So right now there are many hyhealth centers that are reassigning dental staff to primary care support. Remember that both dentists and hygienists are providers. Hygienists are equivalent to mid-level providers and can be used for other functions on the primary care side. And dental assistants in general, we're all very familiar with infection control and standard precautions. This is the NOAA website where we have all of our resources on dental and COVID. Next slide. And these are some resources for oral health and diabetes. Thank you very much. We'll move on to our next speaker. Thank you, Joe.
Thank you so much, Dr. Hilton. So our next speaker will be Dr. Darlene Jenkins, Senior Director of Programs of the National Healthcare for the Homeless Council. Dr. Jenkins, you have the floor.
Great, thank you, Joe. And good afternoon to everyone. And thank you so much for hanging in with us today. We know that it's a lot of information that we're trying to get to you within the hour and a half, and I hope that you're enjoying the presentations thus far. But just hang in there a little longer, then we're going to get to some examples with some health centers sharing some practical information. So if you could just hang with us a couple more minutes, and I'll try to be very quick with my presentation so that we can get with our special guest. Next slide, please. So I'd like to just do a quick poll just to see what type of models those of you who are participating in the webinar are using. Do you use a chronic care model to address diabetes? Are you using the medical home or health home model? Or is there another type of model that you're currently using for your team-based care? If you could look at that, okay. Meaning are you using the medical home or health home model? Okay, I think the majority are using the second model, the medical home model. So thank you so much for participating in that poll. Next slide, please. So just to go a little bit over the models, I'm going to start with some broad models as the chronic care model, as is seen here. The chronic care model is an organizational approach to caring for people with chronic disease such as diabetes in a primary care setting. And this model represents a method for restructuring the healthcare through interactions not only with the health center, but other health systems, including hospitals, as well as with the community. And here you see where you have an informed, activated patient interacting with a prepared, proactive practice team, or the multidisciplinary team that is at the health center, in addition to all the other supporting systems there within the chronic care model. And so this is one model that can be used within a team-based care at a health center. Next slide, please. Also, we have a patient-centered care model that many of you are using, and this is where the patient is the center and the main decision maker within this care model. Clinicians are there to inform, to advise the patient, and to support them. It is really up to the patient to determine what course of action they would like to take. So this is a shared decision-making model. Therefore, the patient, it's very important that they have instructions and information is provided to them so that they can make the proper decisions. And I added in here where there's some interpreters that are needed, and also there have the pharmacy support, the chronic care model coordinator. So there's various models, as well as the community care coordinator. So this is all part of this patient-centered care model to help a patient make the most informed decisions possible regarding their care. Next slide, please. For the CDC promotes the pharmacy, podiatry, and optometry and dentistry model. And I think Irene gave a very good example of how this model may be used in her example with Mr. Garcia. The PPOD, which is the short acronym for this model, they are the professionals that are often the primary point of care for the people with type 2 diabetes. So this is a model that is often used in health centers where this team of providers are the core part of the team, and then they bring in the other parts of the members of the team as needed. And it could be a certified diabetes educator, registered dietitian, anyone else, a behavioral health therapist, anyone else that is part of, that is needed for the multidisciplinary team, health educator. And so this is just an example of the model that is promoted by the Centers for Disease and Prevention. Next slide, please. This is a pharmacist-driven care model, and I know I saw someone who's on pharmacy that mentioned they were left out on one of the models, but there is a model where the pharmacist actually drives the decision-making. So the pharmacist is the point person in this model. The pharmacist collects the information, they assess the patient, they help the patient plan, and along with the multidisciplinary team. So the pharmacist is the point person on this multidisciplinary team. So again, even though there is a point person with a specific title or profession, this is still what we refer to as team-based care. So the pharmacist in this model is the point person, and they're actually the one who collects, assess, plans, implements, and gives the follow-up and evaluate, and gives the information or collects the information, shares the information with other members of the team. Next slide, please. Finally, this one model that I wanted to share is the diabetes coaching model, and they have found recently that adding a health coach to the care team is very important. And this model has emerged as an important model for self-management as well as for care. It's been shown to be cost-effective with chronic disease management and prevention. And the coach, the health coach, diabetes coach, partners with the patient to identify their health goals. They help them create action plans. They overcome barriers to change. They really focus on motivational interviewing, helping assess what the patient's goals are, where they want to start, and then they help develop techniques to help meet the goals identified. They also help with behavioral change modifications, and these visits on this type of model may occur in person or through telehealth. Next slide, please. And this is, and I forgot, I just wanted to go back to the model with the pharmacist. I forgot to add one caveat. I know with that model, with the pharmacist as being the point person, I know one health center has done that model very well. In fact, the pharmacist does joint visits with the primary care physician. So what they have done, they have identified a cohort of their patients that have A1C greater than 9. And for that cohort of patients, the pharmacist actually does joint visits with their primary care physician for those patients. And they sit in with the visit. They give hints, they look at, see how they need to adjust the medication. And then they also, this pharmacist also invites the patient to a cooking class that she conducts. And so the pharmacist is very key in the care of that model. So I just wanted to also share with you that I have seen that work very well at one of the healthcare for the homeless sites, in fact, has shared that model and has done it very well. So this is my final slide before we move on to our special guest, but I wanted to share some of the key messages that all team members can reinforce. One of the important things that I want to, and you can kind of go through these and read this, but one thing I wanted to really point out is to reinforce, the self-exams and foot care and dental care and the others as appropriate, but also to explain the benefits of diabetes comprehensive team care. It's very important that each person really emphasizes within the patient, because many times people say, I got to see so-and-so. Why do I have to see them? Why do I have to see this person? Why do I have to go to that person? So to really help them understand why the team is working together, it's to really give them the optimal care necessary. And also, when we're talking about coordinated care of services, we need to also ensure that we're getting coordinated information. I know many times clients have reported that they get conflicting information from the registered dietitian may say something to them, their primary care physician may say something to them, the nurse may say something different, the MA may say something different. So it's very important not only that you coordinate care, but you coordinate information. Identify the basic facts that you would like to ensure that you're giving that straight line of communication to a client, so they're not getting confused with all the different information that is being said to them during visits or during their interactions with the different members of the healthcare team. And I think, next slide, please. I think that will end my slide. Yes, it does. And so, Joe, I will turn it over to you.
Thank you so much, Dr. Jenkins. By now we have defined team-based care. We discussed recruiting and retaining the right team. We covered team competencies. We talked about what a well-functioning team looks like, and we also discussed a variety of team-based care models. So I just want to once again thank all the NCA faculty for presenting their wonderful content. We are just really, really excited to introduce health center experts who can speak more about team-based care and their experiences. To kick off, I'd like to introduce you all to Tonii, Gedin, Tracy Russell, and Mara Schneider from the Baltimore Healthcare for the Homeless program. So Tonii, Tracy, and Mara, I'm going to give the floor to you now.
Hi, everyone. This is Tonii. I'm the Chief Quality Officer at the Healthcare for the Homeless project in Baltimore. Thank you for having us. Please let me know if you can't hear me, by the way. That's a common, even in person, I get that quite a bit.
We hear you perfectly clear. Thank you for the sound check.
All right, so presenting today, you'll see Tracy Russell, who is a population health nurse that works under the quality division, and Mara Schneider, which is one of the occupational therapists that works at HCH. All right, next slide. So we want to really today help you understand our team-based care model, how we got to this particular model, what's the purpose and the makeup of that team, how they consistently interact, and to talk about some of the challenges, lessons learned, and things that we think are possible for you to replicate at your locations. Next slide. Just a little bit about us. We've been in existence since 1985. We're about 240 staff members at this time, and that's across, so we have a mobile clinic, our main location in downtown Baltimore. We have a clinic in West Baltimore, a clinic in Baltimore County. We also we have a convalescent care program or respite care. I think I've covered it. We also have a freestanding dental clinic in the city's largest soup kitchen. So last year we served about 9,200 unique individuals. Yeah, and that's us. Okay, next slide. Thank you. So we launched our care teams 4 years ago, and prior to our care teams, as when I describe this to new staff members who are joining us, we thought about it as limiting the universe for our our clients and our staff. So if we had, at the time when we started our care teams, I think we only had 2 sites, but we had at our largest location about 14 to 16 behavioral health therapists, 8 to 9 medical providers, 7 or 8 case managers, 5 nurses, and the combinations of people that any one client could be seeing was really kind of endless. So the opportunities to do care coordination were difficult because, let's say, as a nurse, right, maybe my patient is seeing 7 different, or my patients are seeing 7 different therapists and all of the different medical providers and a number of different case managers. So we found that we were typically only case conferencing or really doing in-person care coordination for the sickest clients that kind of rose to the top and said, I really have to do something about this individual. And a lot of other care coordination was kind of scattered, and it happened as people could do it when they found you, if they sent you some sort of message, but difficult to do and hard for the clients to, they would always come to visits, and not to say that this doesn't happen now, assuming that you knew everything that had happened because I just saw the person down the hall 2 days ago. I told them this, why don't you know this? Which I think is a pretty common experience in healthcare. So we decided to create our care teams, which are all color-based. So we have a care team, orange, for instance, is our pediatric team. And we were looking to really be able to improve the quality of the care and the care coordination that we were doing. Next slide, please. So just a little bit about our strategic goals. So this current plan, and we've done a lot of our diabetes initiatives under our current strategic plan. We've said 100% of the people we serve will have timely access to quality whole person care and affordable housing. One of the other things that we've stated in this plan is, as a result of our care, the health outcomes of our clients will rival that of a stable population. And we made these really large proclamations to push ourselves because, you know, we could say, all right, well, we want 50%. I don't know what you say to the other 50% of clients. And if they ask, which percentage am I in? So we said, okay, we're going to say 100%, but we also wanted to be able to compare ourselves. So when we said rival the health outcomes of a stable population, for us, as with all of you as an HCH project, we were able to look at the UDS data and compare ourselves to at least health centers that weren't serving primarily people experiencing homelessness. And that comparison has been really helpful for us as far as, are we actually getting to a place where people are having a closer health outcomes? And we've seen a lot of changes with our diabetes. So we've specifically set out different measures that we wanted to compare and have every year of this strategic plan, it's a 3-year plan, integrated different clinical outcomes that we wanted to see change and goals to kind of help us along the way. Next slide, please. So one of the other things that pushed us along the care team road was, again, about 4 years ago, we were looking to become recognized as a patient-centered medical home through NCQA. And for those of you who are familiar with this model, care teams are a part of something you have to have. So we decided to take it a step further because we could have, most NCQA is primarily focusing on medical care. They've since changed their standards to include a lot more behavioral health, but we decided to take it a step further and say we wanted everyone in the clinic to be a part of our care teams and not just, say, the medical team. So not just your nurse, your medical provider, and a medical assistant, but really expanding that so our care teams include a real multidisciplinary approach. And this is one of the things that we really drive a number of different improvement efforts. We have same-day access for all of our disciplines. We have walk-in access for all of our disciplines, and a lot of the things that NCQA outlines, we've been able to really adapt across the board to all different disciplines, which has been helpful in keeping our care teams consistent and keeping the disciplines somewhat on par with each other. Next slide, please. So for our care teams, this is a little bit of who's included. So there are 2 medical providers. There are anywhere between 3 and 4 behavioral health therapists, 1 nurse, 2 case managers, 2 medical assistants, a community health worker, and our front desk staff support, which we call a client access associate. So they're pretty big teams, but we found lots of great ways to make them work. And I think one of my colleagues will be talking about specifically how the teams interact coming up. But these are our teams, and we've tweaked this and changed it. Previously, we had psychiatry on the team. We do have services that are not included on the team, and we'll get into that in a minute. And I think I'm supposed to hand this over to Mara now. Next slide, please.
So I can go ahead and take over. Thank you, Tony. So within our original care teams, or our designated care teams, which we've represented with colors, we also have additional supportive services that we use within a consultative role. As many of the other presenters have talked about, that diabetes management is extremely complex, and making sure that we're addressing all of the additional needs outside of just what can be provided with our set standard care team providers. So some of these roles include housing services, disability outreach, psychiatry, as Tony had mentioned, occupational therapy, dental, and our convalescent care program. All of these are kind of, they don't work specifically with the team to, meet weekly and follow through with the specific same clients as the rest of the care team, but they're definitely there in a consultative role to provide additional assistance and additional care for when clients need it. Next slide, please. So the next level of care that kind of is the oversight to our entire care team is our quality team. So within this, it includes our performance improvement, population health, health informatics team, and our grants and compliance team. They are able to set some standards for us as well as set goals that we work together as an organization to meet. So Tony had also mentioned that we had certain goals set in terms of getting our health outcomes to rival that of a stable population. One of the reasons we were able to move towards quality care team model is putting an emphasis on reaching those goals and prioritizing diabetes care within that model. Next slide. So how do these teams interact? So one of the things that as an organization we decided to do is we piloted it with one of the care teams. So we used the yellow care team, and what they started to do was we moved their offices so that they would have greater physical interactions with each other in terms of offices were located next to each other or near each other, having the ability to work within the same space as well as working with the same client, increasing that knowledge and interaction and engagement with clients, not only face-to-face with the clients, but like we've heard so many other presenters talk about, really trying to limit how much a client might have to repeat certain information, being really, trauma-informed and trying to minimize the disturbance between one provider to the next in terms of feeling that they need to repeat their story, or maybe that their providers don't understand the full picture of what they're going through. We have daily huddles at 1 o'clock every afternoon for all of the different care teams. What's particularly nice about this is because it's set on a regular routine schedule, the consultants that we had mentioned, including occupational therapy, which is what I do, we're always able to join in on the team meeting. So while the care team is usually a core of the designated disciplines, other providers are always able to step in and also provide additional assistance or information or expressing concerns about a client's care. Additionally, it's really nice because we have further meetings between disciplines. So if the yellow care team is having a particularly hard time with a certain client, and the purple care team has gone through something similar, it gives the different disciplines an opportunity to kind of talk between the color teams and really share a wealth of knowledge to get full client care. And then additionally, we have PI and performance improvement and population health committees, which a diverse number of staff members can participate on. So again, just getting a lot of different lenses on the issue, a lot of great ideas, and really trying to play to our strengths to get as many people committed and engaged in good quality client care. Next slide, please. So we've heard a lot about the importance of team-based care. Each discipline as a part of the team brings a different perspective and different priorities to client care. And what that really means is you get a more comprehensive and holistic approach to client care. So with diabetes specifically, evidence has shown that team-based care results in the better ABCs of diabetes. There's strong evidence to support using a nurse or a pharmacist, as well as a CHW, which is a community health worker, to support interventions for diabetes care. With diabetes care, there has to be attention placed to behavioral health components, particularly anything like behavior modification, motivation, and then we've also noticed a big change with explicit communication over implicit communication, really focusing on direct communication, eliminating any of the space for ambiguity within talking between the different disciplines or between provider to client and client to provider. Next slide. All right, so we have a patient example. So we have Eddie. Eddie is a man in his 50s with a A1C of 12.4 who was hospitalized twice in the last year, once for dehydration and once for ketoacidosis. Oh, sorry, once for dehydration and ketoacidosis and once for stroke. He is staying with his niece and his niece's boyfriend for now, but feels bad about not having his own place. He tries to stay out of their way as much as possible. He is obese and stays in his room most of the day watching TV, where he watches sports games and eats fast food and processed snacks like cookies and potato chips every night. He runs out of money as well for food towards the end of each month. One day recently, on the way to his nephew's house, someone jumped him and stole his backpack, which had all of his refills of his medications, which he had just picked up from the pharmacy. He has been scared to leave the house since, so he has missed his last primary care, therapy, and physical or psychiatric appointments. When scheduling to try to reach him, he couldn't be reached because he had run out of minutes on his phone. So I'd like to say that this is an extreme example of a client, but honestly, it's a very common example of the kinds of clients we work with here at Healthcare for the Homeless in Baltimore. There are several additional barriers that clients within this population face, including not feeling safe within their communities, in addition to maybe not even having a safe place to stay or a safe place to keep medications, having decreased access to food and healthy food sources. And that's just kind of on top of all the other concerns that other presenters have already mentioned. Next slide. So what we did was we broke it down and kind of talked about how each role on our care team really work together to coordinate to get Eddie the best care that he can get. So within our team of disciplines, we've got lots of collaboration, and most importantly, within this collaboration, we've got the opportunity to get some consistent use of beneficial and successful strategies, as well as making sure that the information that we're providing is consistent and well understood. Our population here has a higher rate of traumatic brain injury, cognitive deficits, experiences or past experiences with trauma, And as a result, making sure that the message that we provide as a team to provide that clear, consistent message is really important. I think it also really speaks to the clients when they're getting the same information over and over again. One, it helps with memory and understanding, but two, I think it also provides a sense of security and trust within the organization. So looking at our different roles, we have our community health worker who's able to go out into the community. If a client has fallen out of care, they're able to kind of hopefully locate that client and get them re-engaged in services. They also assist with education and escorting clients to appointments. We have our behavioral health therapist and our psychiatrist who can work through stress and trauma, work on behavioral changes as well as motivation. If there's medication that needs to be in place to help manage other psych symptoms that might also be impacting someone's ability to engage in diabetes care, whether it's managing depression or anxiety in a more beneficial or stronger way. We have our case managers who can help clients apply for TDAP or SNAP and assist with scheduling appointments with our consultants or our disciplines that are not within health, places like podiatry and ophthalmology. Our nurses are really taking a big role in this as well. They have the availability to meet with clients weekly or biweekly, even sometimes daily, for medication adherence, being able to review blood sugar logs or their glucometer, medications lists, and really help to reinforce behavioral changes that maybe the behavioral therapist is already working on. Within the scope, we have also got our primary care physician who's looking to help simplify medications and making sure that additional complications or conditions are being treated and not causing additional complications. For occupational therapy, we usually focus with clients working for cognitive strategies. So again, if memory is very difficult for a client or they have cognitive deficits that make understanding very difficult, working with clients to help teach them the skills that they would need to be able to perform some of these actions on their own. So learning how to fill pill boxes or understanding what each medication is for, working on healthy cooking techniques and skills so that a client would be able to hopefully replicate that within the community. Looking at budgeting. Eating healthy can be very expensive. Same thing with going to a gym. It's very expensive. So for clients that are on a very restrictive budget, looking for opportunities to make these things a little bit more possible. And then we've also got our CAA teams, which are our unit clerks who can assist clients with scheduling. We've noticed, heard another presenter say the same thing, that if you can schedule a client for multiple appointments on the same day, there might be an increased chance that a person can be fully engaged in care, whether it's using one appointment that might be more motivating for the client to attend and kind of sticking on additional appointments to hopefully get them to stay and engage. But also making sure, again, that repetition of information, that clear, concise education is being presented to the client over and over again. The other thing that makes our program unique is some of our disciplines are able to go out into the community and see clients where they are. So our community health workers, we have a nurse as well as occupational therapists that go out to where a client is living and get to see the environmental factors that might be impacting how well they're able to follow through with their diabetes care. And we're able then to implement certain changes that might be able to help streamline the process for the client. Next slide. And now I'm going to hand it over to my colleague, Tracy.
Tracy, this is Jolie. I believe you are on mute right now. I'm going to try unmuting you. Let's see. And it looks like I'm unable to unmute you. If you can unmute yourself, that would be really helpful. So it looks like we're experiencing some technical difficulties at the moment.
I'm happy to step in for Tracy.
Oh, yes, please do, Tony. Thank you.
Yeah, no problem. 1 second. Okay, I'm sure like most of you, we're working from different locations and it's a little bit loud in my house, so I'm gonna step out. So a couple of things that we've really tried to focus on and different challenges. The impacts of the social determinants of health, the SDOH, and how many of those we can actually, I'm sure as many of you know, have an impact on. There are things that we can't change for our clients that might be huge barriers to how they can manage or not with their diabetes care. So I think that's a challenge with this given population, and we do continually collect. We have a social determinants screening that we're using, and I think it provides a lot of great information, but it can be frustrating at times when there's nothing you can do about the thing that might be impacting their care the most. Missing key roles. So I think for the most part, we've been able to pull quite a bit together, but we've had questions, I think, as many of you probably have, about pharmacists. We don't have a pharmacist on site. Registered dietitians are roles that often come up, or specifically diabetes educators who are certified. So our nurses do a lot of diabetes education. It requires a decent amount of continual education in-house to make that happen, but at times there are questions there. A lack of knowledge of standard practice. So trying to make sure that across the board we're doing the same thing. We were fortunate enough to have a volunteer endocrinologist with us for a while, and she was volunteering with the quality team actually, and not to do clinical care. But what she found is that the prescribing practices of providers were kind of a bit all over the place and maybe not exactly up to.
It looks like Tony, I believe you might have cut out by accident. We are going to see if we can move forward, and I apologize everyone for the technical difficulties. Tony, are you still there?
Can you hear me now by any chance?
Oh, yes, now we can hear you.
Oh, good. I'm so sorry about that.
Oh, no worries. It happens to the best of us.
And thank you for filling in for me, Tony. Are we with challenges right now?
Yes, we're currently at challenges. I believe she was talking about lack of knowledge and standard practice, and moving on to the impacting SDOH and communication.
Okay, great. Moving on to communication, it is awesome that we have daily huddles amongst our care teams. However, our practices around how huddles are conducted aren't always standardized across the care teams, which can be a bit challenging. In addition, communication between staff and clients can be challenging. Sometimes staff have goals that they think are best for a client, but part of patient-centered medical care is to let the client guide their care. And so we need to be cognizant about the need to listen to a client and what's most important to them and what they want to work toward. Communication with external specialists can often be challenging as well, as we don't always receive consult notes in a timely fashion or communicate as agilely as we would like. Next slide, please. So we've learned a lot of lessons since starting this work. One of our biggest lessons has been around recognizing the importance of staff training to better equip our staff in diabetes care. Our staff have expressed a lot of appreciation when we've tried to bring in educators, including certified diabetes educators, to provide tips on how to discuss diabetes with clients. We've also found that having care team trainings on how to coordinate care for clients is helpful. For example, we would provide scenarios like the one we presented on Eddie's for care teams to practice working through. And while this might be surprising, we found that each member of the care team hasn't always had a clear shared understanding of one another's job descriptions. And so providing training on what each role does has become a part of our practice. Addressing social determinants of health is extremely challenging, but we try to address those factors wherever we can. Apologies, I think it says find workarounds on your PowerPoint. I had changed that to addressing social determinants of health. So we screen our clients for social determinants of health using questions from the Prepare tool and use that information to connect clients with staff that can address those factors. For example, if clients respond positively to food insecurity questions, they will be connected with their case manager, who can then help connect that client with food resources. And as an agency, we also lobby for policy changes that address social determinants of health, like access to housing. One of our mottos is that housing is healthcare. We also try to play to our strengths. So while we may not have a dietitian or an in-house pharmacist, we utilize the care team members that we have. And so we utilize, for example, our nurses in providing self-management education to our clients, so that all of our clients with an A1C over 9 sees their care team nurse for this purpose. Our nurses also follow protocols that enable them to titrate basal insulin doses when meeting with their clients. They can also track med-taking behaviors and support clients with med adherence and packing pill boxes as needed. And while we don't have a dietitian, our OTs have owned cooking classes and work individually with clients on how to make simple but healthy meals. Another lesson that we've learned is that changing diabetes outcomes is really hard work. I'm sure that a lot of you have found that to be the case. And we've found that breaking up the work into some smaller and short-term goals, as well as bigger long-term goals, helps to keep team members encouraged and makes the work more fulfilling. One way we deliver shorter-term deliverables is through campaigns that help to make the work a little more fun. For example, last summer we created a Rethink Your Drink campaign in waiting rooms, in medical exam rooms, in offices, and we challenged people to drink less sugar-sweetened beverages, and found that to be a great way to really unify people around efforts to have healthier habits. Since we work with a population that often misses appointments, often have a lot of priorities, we found that reaching out to clients who are past due for care helps to keep them engaged. We had our health informatics team create registries or lists of clients, for example, with uncontrolled diabetes who haven't seen a nurse in the trailing year. We've had them create lists of clients past due for their A1C and other various lists, so that our care team members can call those clients and get them scheduled for appointments. We've also learned that pilots are great. We often try our new ideas on a smaller scale before instituting them across the agency. Starting co-locating care teams with just the yellow care team allowed us to test this out on a smaller group and work out the kinks before involving all 7 care teams. And along with the pilots, we've learned that failing isn't a bad thing, because every time we fail in a pilot, we learn something really important. We have found, as Mara mentioned about explicit communication, that the more face-to-face direct communication that happens regularly among care team members, as well as between care teams and their clients, the better their care and their health outcomes. And we have learned to practice patience and persistence. This work of changing agency culture, changing how care is delivered, and seeing positive patient outcomes all takes time. So just be prepared to engage for the long haul, and don't forget to see small improvements as really big wins. Next slide, please. And finally, while we still have a long way to go with improving our care and health outcomes, we wanted to share a few practices that could be replicated in other places. The first is getting agency and leadership buy-in, and this will hopefully allow you to engage actively in this work and be supported in your work. Once we had leadership buy-in, we were able to create a diabetes committee to really help move the work forward. And it was great because members of this group could also serve as champions on their care teams or in their disciplines to get more widespread buy-in. Creating policies and procedures for roles in your agency specific to diabetes med management can help to make the work more easy and nimble rather than leaving this responsibility to medical providers alone. Enacting campaigns in waiting rooms, exam rooms, and offices is a great way to engage a captive audience and spark discussion around healthy behavior changes. We encourage being proactive about re-engaging vulnerable clients and working with your health informatics team to create registries and lists to inform your work, such as reaching out to clients who are past due for care. Access trainings whenever and wherever possible for as many of your staff as possible. An equipped staff means better, more quality care for your clients. Huddle and communicate regularly with other staff and disciplines to coordinate care for your clients. Set up designated intentional times to meet if at all possible, and also communicate often with your clients. They are the ones at the center of care and are the ones that dictate their goals and what's important to them. Know across your care team what your clients' goals are. And finally, pilot change ideas. You never know if something will work until you try. And starting with just a few people first makes for an efficient use of time and energy when scaling up. That is all from us at Healthcare for the Homeless for now. We'd love to hear from you if you have any questions. And we'd also love to learn from you if you have any practices that we could try to replicate. Thank you so much for your time.
Thank you so much to the entire Baltimore Healthcare for the Homeless program team. We just want to thank you for your innovative efforts, Tonii, Tracy, and Mara. I chatted in the message for everyone. I want to acknowledge that we are at the end of the webinar training time at 12:30 Pacific, 3:30 Eastern. However, we will be staying on for about 10 minutes over, 10 to 15 minutes over maximum. If you need to hop off, we encourage you to check back for the recording and please complete the post-webinar survey. We really value your feedback. If you're going to stay on, please join me in welcoming Jamie Carter, our oral health integration specialist from the Health Partners of Western Ohio. So Jamie, I'll give the floor to you.
Hello. I'll try to make it a little bit shorter now, so you can go to the next slide. So we're Health Partners Western Ohio. We have about 16 sites. We have some outreach mobile vans and mobile equipment that we use for medical and dental. We have clinical and dispensing pharmacy in all of our main sites. We have, all of our sites are really different, so we really have to be flexible and adapt our policies and procedures to make the team-based care model work for the different populations that we serve. Next slide. So we are a patient-centered medical home, and with that we have all of our different specialties, and we try to utilize each specialty at every visit that we can. Our EHR allows us to, for each specialty, to see the different documentation, different lab results, so that everybody's kind of on the same page and we get the whole picture with all of our patients. One thing I did forget on there is we do have chiropractor and massage therapy as well. And we really try to just utilize everyone that we can for each patient so that everybody gets the most benefit. You can go to the next slide. So a little bit about our behavioral health and social workers. We have health coaches, licensed community or licensed independent social workers, community outreach workers. The health coaches, they go over the screening tools to really help the licensed independent social workers and the primary care providers determine appropriate treatment plans for the mental health patients. Our behavioral health providers and our PCPs go into the room together to see the patient most often. So that way they use a team approach, so the patient only needs to tell their story one time. And that way it's just easier for the patient and for everybody involved. Our social workers provide resources on a multitude of different things, including domestic violence, housing, food banks, anything and everything that they can help patients have access to. We also have community outreach workers. They kind of act as our case managers. So they will come into the rooms and introduce themselves when we know that we're gonna utilize them with patients. They will go to the patient's home if they're a high-risk patient and they've missed appointments, or they're not answering phone calls when we try to reschedule. So they'll go check on patients for us and kind of just do a welfare check. And then get the patient scheduled back, get them back into the office for appointments. Next slide. Clinical pharmacists. So we have full dispensing pharmacies at all of our bigger sites. And then we also have clinical pharmacists who go over diet education. They do hemoglobin A1Cs. We have the retina views. So we have pretty much anybody and everybody in our sites are trained to do diabetic retinopathy testing that we send out to an optometrist. So before we started oral health integration, they did a lot of oral health assessments for us. Our clinical pharmacists do a lot of medication recommendations for the primary care providers. They talk to them a lot about recommendations and dosages and things like that. And so they also, they do a lot of medication box fills, especially with COVID-19 going on. They're doing a lot of medication box fills, and then we're pretty much delivering everything to our patients so that especially our high-risk populations can stay at home and they don't have to come into the center to get their medications. We're doing a lot of telehealth visits right now too. So our clinical pharmacists also do a lot of medication reconciliations. This is especially important when patients are seeing a lot of multiple outside specialists, or if they're recently discharged from the hospital or nursing home. Next slide. So oral health integration, that is what I do. These posters we have in all of our medical rooms for the patients, just kind of read over and see, you know, that their mouth is connected to the rest of their body, and so that we can just get them kind of in the process of, you know, somebody's coming in to see you that you may not have expected. So that's one big thing with us, is that we've really tried to change the culture of our patients. So they just know that that's just another tool in our toolbox that we use. Oral health integration specialists, we do a lot of diet education, nutritional counseling, oral cancer screenings, especially our newly diagnosed patients with diabetes or anyone with an elevated A1C greater than 9. We try to get them over, and we just walk them over to our dental office, which is in the same building, and take a panoramic x-ray on them. And that is to evaluate immediate treatment needs, see if there is any kind of oral infections that could be causing an increase in their A1C. We also then have our dentist evaluate that x-ray, and then they will have the PCP write antibiotics, or the dental hygienist will get the patient scheduled over in dental for an emergency appointment as needed for extractions. So our patients with diabetes are at a high risk for periodontitis. So they don't always notice signs and symptoms to that. So sometimes our main goal is just to try to ease them into the dental world and try to reduce their anxiety, provide a warm handoff, kind of go over some treatment needs that they might have, you know, just try to ease them into it and get them scheduled over in dental. So with oral health, you have to check your state laws to see what your limitations are for every state. So that is one barrier to this, but you can get around it and make some good progress with patients by having an oral health provider into the medical setting. Next. We also incorporate our financial counselors, our lab techs, a triage nurse because they're all a part of our team. Each role is really important for the patient's well-being. So our triage nurse will come over and get one of our moms to one of the kids being seen in pediatrics, or one of the kids when the mom is being seen in the adult world, get them scheduled and established and make sure the whole family has a place to go. Then the financial counselors will come into the patient room. We try to keep the patient in one room and have every specialty go to the patient, so they don't have to leave. They come in, they get seen in their one room, and everybody comes to them. Next slide. So one of the challenges that we've had, oral health integration was our last piece of the puzzle to really add. And so prior to introducing it, we knew providers would have complaints about another specialist coming in, another person to come into the room to see the patient, use up their time. So we did a PDSA to see how much free time the patient had in the room without an employee being in the room with them. And so we had a good 30 minutes about with the patients sitting in the room. So we knew that there was plenty of time. Our dental hygienists do not take a whole 30 minutes in the room with the patient. So it's really one of those that you have to be flexible. You have to figure out, when each specialist, each person can get into the room to see the patient. But so as long as everybody's flexible, it really, really works. Next slide. And then the benefits to the patients. So we have seen really good outcomes with a lot of our A1Cs going down when we have the clinical pharmacists and the oral health integration specialists, the financial counselors, when everybody comes into the room to help make that patient feel welcome, make them feel like they are, that all we want is health for them. And so the patients start to make this team-based care an expectation, and they really expect to see all of us come into the room to see them, to check on them and see how they're doing. And so we really do try. And so we have really done well with meeting our QI goals because our patient outcomes are better. Patients are showing up to their appointments and they really want to see. So we really try to celebrate with patients when their A1C goes down and try to engage the patient in their own health care so that so they have skin in the game, because it's their health that we're trying to gain. So and then when the patients know that we're rooting for them, they really try to do well. So that's all I had. Thank you so much.
Thank you so much, Jamie. I'm so impressed with just how integrated your services are. Thank you so much for outlining the diverse roles of your team-based care team, and just highlighting the both clinical and non-clinical, or some may call enabling services providers. You acknowledging the implementation challenges and highlighting, most importantly, the wonderful benefits to the patients you serve has been really inspiring. So thank you so much for your presentation. So at this time, I really encourage folks, I know we are way over time, but we encourage the audience to submit your questions in the Q&A box. We won't be able to answer the questions live today. However, we are able to capture your questions and record them on the back end, and we'll be able to provide responses when we're able to. So I just want to once again thank our wonderful guest speaker, health center experts, Tonii, Tracy, Mara, and Jamie, for their time amidst the chaos of COVID-19 related activities. We really appreciate your leadership and all of your mission-driven work to serve the medically underserved communities at this time. So we encourage folks to pop in their chats and their Q&A. I'm going to move on to a couple of announcements before we log off. I see still over a couple hundred people are on, and this is really impressive that folks have time to stay on. So thank you for staying on. I want to once again thank our speakers for today's wonderful presentation, and everyone in the audience for their time to attend our learning session today. Please note that we have 3 more webinars coming up in our 4-part national learning series. We'll be talking about health literacy and pillars for community engagement in the next 3 webinars. So for more information and to register for these webinars, please visit our website at diabetes.apcho.org. Our next webinar will take place on next Tuesday, March 31st, and will be focused on understanding health literacy to improve diabetes outcomes. And it's hosted, this webinar will be hosted by our wonderful friends, our NCA faculty at the National Center for Equitable Care for Elders, Farm Worker Justice, and Health Outreach Partners. And again, this will take place next Tuesday, March 31st at 11 a.m. Pacific or 2 p.m. Eastern. We ask that you kindly take 30 seconds to complete the survey you will receive after today's webinar. Once you leave the webinar, you'll be prompted to click on a website, and Christine has also linked it in the chat box for you to click on for convenience. We really rely on your feedback to improve our resources and to inform next year's National Learning Series. We want to ensure that we are addressing pressing issues and challenges relevant for your health centers, patients, and staff. So for more information about our National Learning Series, please visit diabetes.apcho.org, and you're more than welcome to contact our NCA collaborating partners whose contact information is listed here in front of you. Thank you once again for attending today's session. Have a great rest of the day. Stay safe and stay well. Thank you.